Good morning. It is just still good morning, I think. I think at this stage we've probably got more people who are going to be on the panel than in the audience, but that doesn't. Let's try and get some energy in the room anyway. Okay, so I'm going to step aside a bit so you can see the title of the presentation. We've got a group of people here who've all been working together through something called the 5G Testbeds and Trials Program, which has been funded by DCMS, the Department for Digital, Culture, Media and Sport, the Ministry for All Good Things in Life, and that makes everything work for everybody else. I head up program development in that program, so my job is to come and spend time talking to people in the wider market outside of Whitehall, outside of the technology space, to find ways to make the technology work and do good things for society. The mission, if you like, or the vision of the program is to build the business case for widespread, deep and meaningful implementation of 5G technology across the nation, and to make sure that we get the productivity gains that 5G promises. And that's not easy, as our speakers in the next few sessions will make clear. It's complex. I'll warn you that there's an awful lot of complexity around 5G. It's not just another generation of mobile in the way that perhaps 3G, 4G as a progression went. It's a completely different way of building mobile networks, and it's a completely different way of bringing mobile and fixed networks together, which should mean that it's much more efficient and much more cost effective for operators to build those networks and to bring those networks together with software and with other capabilities like AI, robotics, and all the good things that healthcare applications rely on to make healthcare more efficient and more effective. We're also here to build the ecosystem for 5G technologies and usage in the UK, and we do that through an organisation called UK 5G, which is led by Bob Driver, sitting here. Put your hand up, Bob. We've got a few numbers on it in a minute, but the point is we've got to get people working together and collaborating. You've heard that a lot in the sessions this morning about collaboration between very large organizations and very small organizations. A lot of the really interesting, innovative stuff comes from SMEs, small, medium enterprises, doing stuff where it starts with an idea with somebody working in an attic or a garage, comes up with an idea. How can they get that to scale? How can they get it to market? UK 5G plays a really big role in that, as does our program. And the last thing is then leading that research and development around 5G. So working with people right from the likes of Ericsson, Nokia, and the other major names in the world of 5G technology globally, right the way down to a whole slew of really nice new companies coming out of the UK, who we've brought into the program to work with end users from organisations including the NHS and local authorities, local care providers. Of course, it always helps with a program like this if you've got a bag of money. And we started out in 2018 with £200 million worth of taxpayers' money, which has been spent very wisely. We're nearly through it now, and the program officially comes to an end at the end of March next year. It will continue on to make sure we close out the program, get the value from that investment, and where necessary, we will extend some of the projects to keep moving. But our real mission is to now go and start spending other people's money from other government departments, other funds, places like Horizon Europe, UKRI, but also NHSX and the Department of Health, to find where people really want to spend that money to good effect. This is Bob's periodic table of 5G. These are the projects that we've funded. There are roughly 34 projects running at the moment, and some that we've completed. As you can see, in they're divided in here between sort of place type deployments and vertical market segments. So you see a few there that are in the health and social care column in particular, and Anne is going to talk later about the Liverpool trial in particular, but we've also got West Mercia, that's Hereford and Worcester to you and me, and we've also got quite a lot going on in the West Midlands on health and social care. So you can see that it goes pretty much the length and breadth of certainly a lot of England, quite a bit of increasing work in the devolved authorities as well, and across lots of other sectors. So everything from driving autonomous 40-ton trucks around Nissan's plant in Sunderland, to cranes in Felixstowe Port, to next generation entertainment with Edge XR, Vista, etc., where the major entertainment and sports providers are doing great things with 5G. But I wanted to focus today, because we're talking about healthcare here at Giant, on the healthcare use cases that we've worked with. And you can see that Anne's been very successful at getting lots of different use cases to work across Liverpool. I'm not going to steal her thunder here to talk about them in any detail at all, but there are lots of different applications for 5G technologies that mean that it's a very effective way of delivering health and care in an urban environment like Liverpool, and Anne will talk more about what that means. Capsule endoscopy is one of my particular favorites, and I've almost experienced it as far as putting on the device but not actually swallowing the capsule. But during COVID, the queue for capsule endoscopy has gone up from 100,000 to 500,000, sorry, 600,000. So that's a huge queue for people waiting for that diagnostic service. That's going to be reflected in some really bad outcomes. That's the real issue. If we can send a kit to somebody to drive their own capsule endoscopy, their own endoscopy response at home, they're in control of it. They don't have to travel. It frees up a surgeon from having to be using a theatre for that process, and it can all be done from home. 5G and high quality communications infrastructure is required to make that work. You can still post the capsule or the film that the capsule's made at the end of it, but it's far quicker if we can do it over the airwaves. So that's one of my favorites. I'm not going to talk any more about those use cases, because they're all documented on Bob's fantastic website, which is called uk5g.org. It's free to join. Anyone can register. If you've got a product that's really good for use, or a service that's really good for use with 5G, you can also register that service on UK5G's supplier directory. So that's a really neat way of getting another free way of promoting your products. And people do go and look at it. Bob, I'm not sure what the traffic numbers are, but there's lots of people who look at that site every day. And all of the use cases, all of the project case studies are on there. I think I'm out of time, aren't I, Catherine? Yeah, okay. So thank you very much. I'll pass the mic to who's going next? Simon, who's going to explain to us a bit more about 5G, I think.
Thank you, Tony. I'm Simon Fletcher. I'm the CTO at a company called Real Wireless, which is based in the UK. We're a consulting and advisory firm, as the name suggests, in the wireless sector, but we also look more generally at networks. I'm waiting for my slides to appear. There we go. Okay. I'm also speaking here with my UK 5G hat on. I'm in the advisory board and co-chair the international working group. So I'm very keen to see export and import opportunities generated through the 5G buzz as we go along. Okay, so I'm going to see if this magic button works, and it does. Super. I've been set the exam question when I was shown the agenda to explain 5G. That's a tough one. But I thought I'd start with this diagram because I think it helps just to clarify that we're talking about, as was mentioned in the previous presentation from Tony, this is this is a converging story. So you have a fiber, backhaul, Wi-Fi, cellular, classic cellular, 4G, 5G cellular technologies, all coming together, ideally not just working outdoors, which is what we're fairly used to, but also working indoors in an orchestrated and an efficient way. And that's what 5G is trying to achieve. You could say ubiquitous connectivity, so that many use cases can be accessed from many different environments. The other thing that's interesting about 5G is the buy-in from the government sector. In the 3G, 4G periods, it was mostly the mobile operator sector pushing and growing their businesses through technology adoption, with smartphones, standard basic feature phones going towards smartphones, making sure that they kept their sector productive and efficient, working off business to consumer revenues. What happened, and it was a switching point in roughly 2015, was the recognition of the value proposition of 5G around digitization and transformation, and the fact that it was in theory going to be everywhere, ubiquitously available. And governments woke up to the social benefit that could be bought through the use cases. And Real Wireless has been on a journey through the in Europe and also in the UK, working on studies where we've converged technical and economic thinking to come up with techno-economic thinking about investment cases, GDP impact. So in particular, highlights the socio-economic studies that we did for the European Commission, where one of the key areas that came out in terms of GDP and benefit to society was clearly healthcare. It's an obvious one, but there's some big figures there in terms of the benefits that could be accrued for societies in Europe. And so that's driven a lot of thinking in the 2015-16 timeframe in terms of the investment and the government wanting to get involved in fiber and wireless related connectivity. And the goal is to get to a point where we're enabling many different use cases in many different environments, indoor, outdoor, campus-like environments in hospitals where you have multiple buildings and people are moving between, everything ideally working seamlessly on some good quality devices. A lot of use cases, potentially you could say, well, they can be delivered by Wi-Fi, but the benefits of 4G, 5G is you start to have a more effective mobility. So when you're moving, for example, a patient in an ambulance from a town, from a city into the hospital environment, there are some services that can be running on the ambulance that are seamlessly, ideally, available to the staff who are in the ambulance, and then the practitioners who are in the A&E and other departments, data flows, similar use cases available on their devices, etc. So that seamless end-to-end is what we're looking for. This is going to be my most complicated slide, and this is really, frankly, this is where a company like Real Wireless earns our money, because it's not that simple, as Tony said. When to get these systems to work seamlessly, we need to think carefully about how we're dimensioning systems. And 4 important perspectives will be: how much spectrum do you have? So the airwaves availability for to carry the data, to carry the use cases. What sort of coverage performance do you have for the systems? Is there enough capacity in the system? And importantly now, which is emerging, driven by a lot of the use case thinking, is quality of experience. To a secure quality of experience of an application or a service on a mobile device, you need to start playing with many different variables available in the network or on the devices to start tuning. And here you can see we were working on a use case for an ambulance recently. And there are some aspects, there's a difficult eye chart to look at, but look, just look, if you can see, you'll see some red dots, which are 4G, and then some blue dots, which are 5G capabilities on an envelope. And then you can see we've drawn some lines to show for a particular use case, which performance envelope you need to secure against various key performance indicators to secure the use case performance. But to achieve that requires a balancing of various parts of the system to ensure that you have a consistent quality of experience, no matter where you are, in the building, on the ambulance, in the patient's home, etc. So that's an area where you start to see actually some of the use cases can be delivered on 4G, and that's fine. 4G starts you on the journey. 5G starts to increase the performance envelope. So that's really a technology push through of the world. I'm now going to say, actually, we need demand. So the technologists have shown that there are lots of clever capabilities, but the recognition that the demand side needs to understand what capabilities they could have and think for themselves, co-creation wise, about how to utilize is a lot of what's happened in UK 5G in the last few months. Delving into 4 key sectors, but I'll just focus here on health as a sector where there's now a hub that's been created, and there's some thinking there driven through that hub that's architected in effect through workshopping with the health and social services sectors. So it's not people like myself, technologists, saying, oh, we can do this weird and wacky use case on that one. It's actually trying to get to the reality of what are useful use cases to be provided. And there's a focus in terms of how the needs of the sector are being brought together and articulated. I recommend you go on the hub so you can see it, but it's in effect a classic strategic marketing segmenting of the market of the needs. And it's quite useful because it helps to frame the required capabilities of the systems and how they need to bring value. So here, these different sectors are addressed, and I'll come on to a single slide that just shows some of those. And there are some key points that came out when workshopping with the sector around how 5G could, 4G, and then the progression to 5G could help the sectors. So enabling more inclusive, accessible care for all, strengthening the security and resilience of the NHS systems, data-driven. Always this data-driven element comes out when we're talking about these use cases. And so that's data engines, data layers, accessing that, and increasing connectivity with scalable solutions. So these 4 key themes emerged as being important, and then you have the needs which can be addressed. And the sort of thing that we've been doing as Real Wireless, we've worked with the UK 5G on this in particular, is starting to work out the roadmap. And the key point that I want to just get across here to you is there are many different use cases. We're just selecting a few, and you'll certainly see if you go into the 5G ecosystem supply side, lots of interesting chats about remote surgery and zero delay like scenarios where there's mixed reality coming together with some drone capability. But actually, a lot of those features are still to be standardized. And the key point about these systems is that we're trying to standardize and create interoperable systems. And therefore, it's key that the standards, the technical standards are supporting, and they're not already, they're not mature. So it's early days, and within 1 to 2 years, somebody could be, for some of the simpler use cases, having 5G services, but it's a journey. And not all use cases are available today, and that's why it's a great time to be engaging with 5G, because you can shape and influence the requirements of the more advanced features and use cases. And that's it from me, and an invite for you to please contact me if you have any questions. We're going to publish a paper. We're also making that paper available on the UK 5G portal as well for the hub. and hopefully that will be informative. And thank you. That's me done.
Hi, my name's Anne Williams and I'm a Commissioner of Adult Social Services in Liverpool, and I'm the lead for our Liverpool 5G Create for the council. You can't really see it because of the lights, but there's a list of all of the partners in our consortium, and we're very fortunate that in the city we've got a lot of buy-in from both the NHS and, as I say, the council, both universities, and the one hiding at the end over there is Tele Research, and they're actually the 5th mobile phone operator in the country, and a lot of people have never heard of them, but actually they can provide the same services as the big guys, just on a more tailored and a bespoke way. So what are we doing and what we're trying to address? The main things that we found is that the biggest barrier of introducing some of the new tech is actually reliable connectivity, and particularly a reliable connectivity in people's homes. So whilst we've got some really great things, if it's not reliable, if you can't get it in your own home, if you're trying to run something in the community, then it's not worth having, really. So we found that the digital programs, and there's a whole, we said in Liverpool we had more pilots than the RAF, but our health service system has had so many pilots of some really good technology, but in effect, it's never been taken up long term because it's not really worked out who's going to be paying for it, where there are any cash savings, what actually are the benefits. And I think the public sector have come in quite late to benefits realised to try and actually monetize what actually the benefits are. One of the big things that we have found also is that there's an increase in tech charge. As we get more and more tech out in the community, there's more and more connectivity charges, and the data charges can really have an impact and start to stop people from wanting to use digital ways forward. And then obviously we've got a huge issue with digital poverty and the impact that that has on health inequalities. So, for example, there are some really nice new techniques for immunology in cancer. So, and they're really getting some wonderful results in stopping what were previously terminal cancers for soft tissue cancers. But the immunology, if your body rejects it, it can kill you. So you need to be monitored very, very closely all the time. And well, you can't stay in a hospital for 6 weeks to see whether you're a kill or a cure person. So you could go home with the right device, you can be monitored. But does that mean it's only going to be available to the middle classes like all of us who've got decent broadband in our homes? So we've got to make sure that the new services are available for everybody. And the reason I got involved from a social services point of view is that as we start to introduce new digital and technical ways to keep people safe longer in their own home, the current telecare market is very analogue. So it's all on copper wire, and that's all going to be switched off in 2025. So we try to find ways of delivering in a different way. So this is lots of words, but basically, when I became aware that the analog line was going off, I initially got money from Europe and we put in a LoRaWAN network, and we were trying to use LoRaWAN, and it's great. And I don't want to, I do talk quite regularly at events like this, and I have said in the past that it didn't work, and that's wrong. It did work, but it wasn't able to provide me with the voice because the LoRaWAN network data packages are too small, so they can't actually carry can't carry voice over. So we had an incident where a guy fell, pressed his button, and he could hear his phone ringing, and he knew that that was help, but he couldn't get to his phone. So we need something which would which would make sure that nobody was left in that situation. So the DCMS test bed and bed trial came up, and we were successful. And those figures in there, that we got 248k savings from 100 service users if they use things in the community, is quite a powerful figure. And we're trying to convince the NHS that they should be investing in this. And we're now 5G Create, because that first one was just using Wi-Fi, but we're now actually using our own SIM cards, and we're using our own network. So obviously we've got district nurses who can go around using AI on a device, and there's the opportunity for all of the mobile workers, both in the NHS and the council, to be able to have that. And obviously our data charges then plummet as an ongoing cost. So this is what we're doing. So we've got at the bottom our fibre network. So we have our own CCTV fibre network, and then we're putting it up onto our CCTV cameras, and then it goes across on a millimetre wave and also cellular around on the lampposts and into fixed lines onto hospitals or community settings. And then we've got, there's pictures of a whole range of the types of devices that we've trialled. We're very fortunate that in Liverpool we've got AIMS, which is a data centre, which has got NHS status for a health data management. So research, etc., can take place through that data centre. And the NHS particularly like the fact that we've got our own SIM card. So that's an extra security level that we've got in there. And that's a wonderful CCTV camera, and it's been quite painful to get there. But all of those wires are actually connecting a cellular and a Wi-Fi and a LoRaWAN net. All of those are coming through there. If any of you guys can devise me one box that's less than 9 kilograms in weight and that I can stick up on my lamppost without all of those wires, come and speak to me. And what we found is, because we were trialing this, we got lots of SMEs coming to sell me things. We could try all sorts of things, and there was all sorts of solutions to problems I don't have. So the most extreme of that was when a guy came to sell me a Japanese-style toilet for care homes. And the average age of people in a care home is 83. Most of them are incontinent, but his toilet had a unique selling device of being actually able to tell if you were pregnant as you urinated. So if we found that that was going to be of any use, apparently he told me that the nightclubs in Japan, they're a big hit. What a night out to find out if you're pregnant. But it was never going to work in our care homes. So as a result of this and my frustration, my colleague, who I will flash a photograph of her at the end, were the most unusual digital disruptors, because we're women of a certain age. And she has actually, we worked out with her and her team on an adaptation readiness level. So many of you will have heard of TRLs. We're now talking about ARLs. So I won't speak to any of the SMEs who want to sell me anything until I know what their ARL is. It's a free device. We've developed it using the money from Tony's situation. And then this actually tries to put it into the 5 dimensions. Is the market ready for your innovation? Are the people involved who are going to use this? Which 83-year-old thought she might want to know if she was pregnant? You know, those sort of questions. Systems integration, how does it integrate with the existing system? And the finance and procurement, who do you think is actually going to buy this? Are you expecting commissioners like myself, or are you expecting individuals? And if it's individuals, how does that get into the system? So I'd recommend, if you go on to the eHealth Cluster website, you can do a free online ARL, and we're trying to promote that very much. So these are the key challenges that we're trying to address. Obviously, many households can't afford. So in Liverpool, as a city, we've actually got quite good connectivity, commercial connectivity, but actually we've got quite a low uptake in some areas, and that's on basis that people can't afford it. So they can't afford the £22 or whatever it is a month. And that became a real issue, obviously, with the pandemic. Have you ever tried to live your life without using the internet? You can't buy things, you can't, fill in any government forms. So as local and central government go online, you really need to have access for everything. And that's just basic living now. So that is really one of the main drivers that we have. And obviously the digital divide has got wider in the COVID, and we're trying to make sure that we've got a sustainable answer to that, that we can actually work with people and communities to make sure. Actually, most libraries, their biggest footfall now is for the use of their computers. And when actually the libraries closed because of the COVID pandemic, that whole cohort couldn't access the libraries, couldn't access the internet. So there's there is a huge issue there that we need to address. Our city is wonderful and we're really nice people, but we've all got rubbish genetics, so we don't live very long. So we've got actually a very complex health challenge, and poverty is actually one of the key drivers. There's all sorts of research going on to see, because although I'm not living in poverty, my grandparents were, and what impact that has on my genetics. So there's a lot of, it's not just one generation thing. And we found that there was a slow adoption. As we said, we had lots of pilots, but it was difficult to get that to be then mainstreamed. So we're trying to work together. That's why our consortium involves all of the local NHS as well as the council. And one of the big issues, and the reason we've got the NHS's attention, if I'm honest, is that the increase in their costs. So our local CCG pre-pandemic was paying £6,000 a month for the GP, for want of a better expression, their telephone bill. So the GP's connectivity costs were costing them £6,000 a month. The height of the pandemic, it was £90,000 a month. So that huge increase means that that money is taken away from the frontline services and going into, into commercial reasoning. So if we can have our own ubiquitous civic data, civic network, and we're out in the community, and as I say, the staff can use our SIM cards, those costs go right down. So the business case, and we're working with Real Wireless, the business case that we're developing is demonstrating that the management costs would be far cheaper than the ongoing data costs. So, and then the final one, I think, is Rosemary and I, who, as I say, are the most unlikely digital disruptors.
Thanks, Anne. So I'm Catherine Gall. Oh, goodness gracious. I don't really need the microphone, clearly. And I am with Cellnex. And I'm going to tell you a little bit about Cellnex in a second. But what I thought I would do is we're at the halfway point. We have an hour and a half, and we want to create a story for you here. We wanted to create a story of, what government is doing about how 5G, they see 5G working in healthcare. We wanted to show you what was going on actually. So within the community and outside of the hospital, we also want to look at what's happening inside of the hospital. And I think Simon very well explained about 5G. You're going to have probably hundreds more questions. And Simon and the whole gang is available to answer them. And we've got a panel at the very end. What I wanted to do, I think we're ready to go now. What I wanted to do, though, is tell you what's going to happen after I speak for a little bit, is we're going to start to go into the hospital a little bit. So there's out of the hospital, how 5G can impact. And I think Anne did a great job of explaining that. And we're going to go into the hospital. So next slide, here we go. So here we go. Cellnex, who is Cellnex? Nobody knows Cellnex, pretty much. They are a 36 billion euro company. They are something called a tower co. So in 12 European countries, They own around 128,000 towers upon which mobile operators put their kit in order to have mobile networks. So we are very much involved in that outside, getting 5G to the communities. What I do is I work in an area called private networks. And Cellnex, about 18 months ago, bought a company called Edscom, which was based in Finland. And Edscom is a company that is actually working exclusively on private networks. And I'm going to explain a little bit about 5G and private networks, the difference between private networks and public networks. And I'm not going to take very long because the most important content comes from the folks that are here that actually work on the front line. So these are some of the challenges that we've identified that hospitals and actually the NHS, both inside the hospital and outside the hospital, have. But if you take it from the inside the hospital version, goodness gracious, they can't find things. You can't find a crash cart. You can't find the pharmacy cart. You can't find beds. That's a big one. So how do you find the beds? There's environmental issues that they have to deal with. How are they going to manage those? You've got unplanned maintenance on equipment that actually keeps people alive. How are you going to deal with those? We're going to show you a little bit about how 5G and working with private 5G inside of hospitals and outside of hospitals can answer some of these questions. So what is private networks? What are private networks and what is private 5G? Essentially, a private network is a network just like a standard mobile network, but is purpose-built for a specific location. So in the case of a hospital, it is purpose-built for the hospital, which means that wherever the hospital needs to have connectivity, the network is driven specific, or the network is developed and designed to have connectivity in that area. So if you need connectivity in the closet that has your drugs, or in the operating theater, it has connectivity there. It's also highly available, which means it's reliable. It's going to be on when you need it to be on. To Anne's point, it uses its own SIMs or connectivity, which means only the people or things that you allow it to have access, have access to it. That makes it really super secure. And it gives you the ability to have all the features that Simon talked about with regard to 5G, which is low latency, ultra low latency for things like using in an operating theater, or drone delivery, or something like remote health. I have a story about remote health, if you can indulge me. I'm not the healthcare person. My stepfather had a stroke on Christmas Day night. And if anyone knows about a hospital on a holiday, especially Christmas Day, with a critical event, you don't want to be in a hospital on a holiday. So the ambulance took him to the hospital, and somehow my mother and I got back into the working bowels of the emergency room. We slipped in with the emergency ambulance crew. They had taken my stepfather to a room to have an MRI, and behind me, they had wheeled in a screen on a pole. And on the top of the screen on the pole, there was a doctor that they dialed in. And that doctor asked my stepfather questions, talked to the technician, and he was wheeled out. And another doctor was wheeled into the next room. He was probably at home, he was on call, he wasn't drunk, but he was probably at home celebrating Christmas with his family, and it might have taken him an hour to get to the hospital. But he was there right away. And that is the power of 5G in a hospital. So if you'd indulge me for a second, I'm going to exchange a little bit about the difference between public and private. So in a hospital, you might have a public network, and you might have a private 5G network. The public network might be everywhere it needs to be, just like the private network. The difference is security, reliability, and then you know exactly what you're going to get from your private network. You know that the latency that you're going to get, the throughput that you're going to get. So using some of these applications that Anne has been talking about, and that some of our future speakers or subsequent speakers will speak about, they know that they can rely on that network. A critical event that actually causes the population, the patient population of the hospital to grow could put too much pressure on that public network. And if a hospital is relying only on a public network, it could actually degrade services there. So that's the difference. And that is all, because I am the least important person talking today. It is all about the people in the NHS, and Anne and Peter and Joanne and a few other people who are speaking today that really can inform that. So I'm going to turn it over to Peter. Thank you.
Thank you, Catherine. Is this green button, is it?
It's Joanne next. I think it's Joanne.
Oh, okay.
Apologies. It's Joanne next, you're right. Got it? Okay, thank you. Apologies. My bad. So Joanne, unfortunately, is based in Spain, and he has kindly joined us remotely. Thank you.
Okay, good morning, good afternoon. I'm in Barcelona. Happy to be here with you, but not presentially. Anyway, let's talk today, as Catherine talked before, what is going on in a hospital from the clinical side, because finally the users are the important people, the people using the networks. Clinicians are trained to diagnose and treat ill health. Most of them, they want to provide high quality care. High quality care is the most important thing in healthcare. And which is, as a part of Catherine said before, as have a seamless integrated care, to have more time to care for our patient and less paperwork, to be able to have remote monitoring of the patient, to have higher speed in the process of diagnostics, not waiting for days or more time, to have easy access to quality data. It's very important how we have the data. And in health, we have all the images and all the processes, a lot of data with a big volume of charge. And this quality data should be accessible whenever and whatever. Another area is the patient safety and the greater security throughout the clinic process. At the same time, doctors and nurses and all clinicians, they're ready to be trained. Usually, there are people having auto-training. But the whole thing is basically the fact clinicians are willing to use new technologies if they can help them to provide high quality care. That means that is the basis. They need connectivity. And one example of that is this slide. I like to explain to you briefly because it's very complex. Is a slide where we have mostly technologies already into the market nowadays, in digital health, in big data, and precision health. And they're immense, they're numerous, and all of them, they have other technology behind. But the important thing here today is, in this slide, is to show you, to make you aware of the importance of the links among them. You see all these colored lines there is the links. That means all technologies, at the end of the day, they are connected each other. You're going to work with one single technology. You need more than one, or more than two, or more than three technologies connected. That means we need in the practice, in our practice, in the hospital, we need a lot of capacity to connect the different areas of knowledge or different tools from the digital, from the big data, or from the precision medicine. That is the fact nowadays, and what is for sure in the coming months, the coming days, the coming years will be more technology. That means that is growing exponentially. And one example is similar, but is more focused on digital health. Because at the end of the day, we have the convergence of biotech, medtech, and digital in the same area. And we have in this slide, we have the big data, we have the health IT, e-health in itself, and gamification. And again, you see all these lines linking different areas of activities, either technological or big data or games or wearables, etc. That means at the end of the day, we have a very complex situation where to work properly, we have to be able to connect properly every area, every tool we have. Example, and is the more visible, is the hospital. In the hospital, we have so many services. I don't have any statistics, but if we have a research on that, probably in a hospital daily, there are thousands and thousands of connections, either personal connections, machine connections, image connections, videos, conferences, etc. The hospital, we can say, is like saying is a big box of communication, because without communication is impossible, not only inside the hospital, but outside. For example, ambulances, accidents or problem or heart attacks and company. The importance to have the connection between the ambulance and the hospital, the connection with the surgery room, with the other diagnostic plant places, or the way how we have all medical records accessible in a second, or how images can be seen in a second, how we can be working in a complex process with new tools. That means everything here looks like to transform the hospitals, and for sure will change in the coming years, because we need to transform to better and to do more safe services. That means we have to have connection. And that is why 5G is an important tool, because it's not only a little better, it's changing the way we can communicate, as Catherine said before. That means at the whole thing, all the clinicians, what they want is to do their best. And 5G can help them to do their best in this area of connectivity, of course. Taking into account not only what we have nowadays, what we will have in a few years in the future. And on the whole, summarizing that to make it brief, I think clinicians are ready for technologies, clinicians are ready for having new tools to work, but if these tools are really improving the high quality in the care. And summarizing a sentence could be saying 5G is a high quality tool, can help connectivity, helping to provide high quality care. That is the fact. And the important thing here to finish is how doctors, nurses, and all clinicians are aware, and they know these advantages, and they know how to use and how to can provide to the managers the needs to be fulfilled by a better connection to have better healthcare. Thank you.
Okay. Second time lucky. So this is me, Peter. I work for the NHS. One of the ways that you can tell that is because of the amateurish nature of my slides. I work for a group of hospitals, hospital trust in Hampshire called Hampshire Hospitals. We operate 3 sites. Basingstoke North, Royal Hampshire at Winchester and at Andover. We're a reasonably decent-sized district general hospital. We have some problems around our buildings, and as a result, we're part of the new hospital programme. So we're looking to rebuild the Beijing Stoke Hospital, and that's partly driven by the fact that it's basically made entirely of asbestos, and partly because our population has some real demographic challenges. So we've got quite a large population growth happening. We also have an enormous increase in our over 90 population that's projected. And like most of the country, we've got increasing numbers of comorbidities, so asthma, diabetes, COPD, and increasing levels of problematic behaviours, so sedentary lifestyles, smoking, illegal drug use, and all of the other things that go along with modern living. So if we do nothing other than what we're already doing, we're projecting a need for an extra 225 beds. It's about between a fifth and a quarter increase in the size of the hospital that's needed. Now, the new hospital programme and the Treasurer have been quite generous in cash terms with what they're providing us, but not to that level. So one of the other ways you can tell that I'm from the NHS and not a provider is that I spend quite a lot of my time trying to persuade people that there are good ways that they can not use our services. So we have really two kind of main areas of focus in that. We're looking at a program that we call Without Walls. So that's getting either preventing people coming in to use our service in the first place. I like this tagline: the best patient is the one you don't have. But also looking at ways to get people home more quickly. That's not just because we need them to be home, because we need those beds for other sick patients, but actually because it's a better place for them to be for their own mental health, and also because it supports activity. And then if we fail and you do end up in hospital, we're looking at what we're calling a digital intelligent hospital. So that's really improving the way that we use our theatres in particular, but supporting ways that patients can come in and out of the hospital more effectively. And big buzz for us, we're looking at becoming a planetary health site. So I'm going to talk a little bit about what that looks like, and also how Cellnex are helping us by providing that kind of level of connectivity so that we can so that we can connect with our patients wherever they are, regardless of whether they're in hospital or not. So this is our bit about keeping patients out of hospital. And on the left-hand side, these are the kinds of things that we're looking at doing, which will try and prevent people coming in the first place. So we're doing a whole load of stuff around predictive analysis. We've got some really interesting stuff going on, particularly around cirrhosis of the liver. Don't know how much you know about cirrhosis. It's a really hideous disease. Most people don't know it until they pitch up in A&E with a whole raft of symptoms which are really unpleasant. So if we can identify those patients earlier and start intervening with them to look at lifestyle changes that can prevent that, that's a huge win for us and an even bigger win for them. The other things we're looking at are activity monitoring. So we're trying to improve the level of activity, particularly in our older population, and also to ensure that they are active. We're also looking at sort of supportive technologies, so things which enable both professionals to engage with those patients that are at home, but also bringing in social networks, family networks, so that we're supporting those people to keep sicker patients at home, but dialing down the level of anxiety that those social networks and families have, so that they can remain at home. And then the other kinds of technologies, so remote support technologies, which we will be sending patients home with after their acute episode. We've already started a clinical communications centre, so we have a number of clinical staff who sit in an office and operate a number of virtual wards. Again, remotely keeping track of those patients in order to keep them at home and support them at home. We're looking, as part of the new hospital build, around some kind of WISIA type technologies, so direct delivery, both internally to the hospital, particularly around pharmacy. So we're looking potentially at having no pharmacy on site, and just have an on-demand system delivering drugs either as TTOs to take out medications to directly to patients' homes, and also to wards when they're required. So that's trying to keep patients out of hospital, but also we're looking at ways that we can use the estate that we're building more efficiently when patients are in there. So there's a whole raft of things on the left-hand side that we're looking at trying to do to improve the way that individuals access our services. So that's from mixed reality wayfinding. So have a picture on your phone and you follows you around and gets you to where you need to be. Equipment tracking is a nightmare, particularly in A&E, but also on wards. Really basic stuff like somebody's forgotten to recharge their laptop, so they'll just walk onto the ward next door and nick theirs. And then it's gone, and staff then spend sort of minutes or hours running around trying to find the right piece of equipment. So we will develop a digital twin as part of the new build, and on that you will be able to see the location of the equipment that you want to find. We're looking at multi-resource scheduling, particularly around theatres. So you've got the patient, the staff, the anaesthetist, the surgeon, the room, and the diagnostics and the consumables all booked automatically when you know what procedure is going to be done. And we're looking at sort of real-time bed management, so we know who we've got, where they are, when they're due to go home, and how they're getting home. So that's going to generate an enormous amount of data, and through 5G, a lot of that data is going to be around locations, both in the hospital and out of the hospital. And that gives us a real opportunity to do some really interesting stuff around some of our uninvited guests who are down the bottom in this on this slide. So we know, like all hospitals, that we have problems around MRSA, around C. diff. We've now add to that list coronavirus, but rotavirus is still a problem. Those will still be a problem when we've built the new hospital. But what this does do, what the location tracking data enables us to do, is to triangulate the movement of people, equipment, and stuff with the movement of disease around the hospital. So we could become a sort of living lab for hospital-acquired infections and the interventions that are able to help manage and suppress those. And we're talking to some of our local research facilities, University of Southampton and Winchester, and IBM, who we have on the doorstep as well, with a view to trying to get that, trying to turn us into a facility where we can address this long-standing problem, and 5G gives us an opportunity to do that. So that's me done. Really, this just to sum up, we aim to use the technology better to predict health and disease, to support patients being healthy and active, to understand when things are going wrong and to intervene early, to make patients and staff's lives easier. You know, that's really important. And to reuse the data that we get to address real world problems that we have. Thank you all for your time.
So now we have Jeanette Hughes, who will be joining us virtually, and she will introduce herself.
Good afternoon, everyone. Hopefully you can hear me. My name's Jeanette Hughes. I'm Director of Planning and Performance for the Digital Health and Care Innovation Centre. And as you can hear from my accent, I come from Scotland. So delighted to be here as part of the panel today. Just to start the presentation, and I think Simon and Tony both touched on this, I suppose we need a political appetite to transform services. And I think it's very evident that all governments, not just in Scotland and England and the four nations, but every government around the world is relying now on digital. Digital offers a promise to meet some of the targets that all governments are laying out. And I think the most critical one immediately is the remobilisation and recovery of COVID-19. I've worked in this industry for the last 10 to 12 years, and the demand on the services is always been talked about as a crisis point. This is the first time I've actually seen it really in crisis, you know, where people are queuing outside hospitals, there's not enough hospital beds, the ambulances maybe are taking 4 hours to appear at somebody's home. So there is now a great willingness by the service to innovate using digital, and that includes obviously 5G. The other aspect, I think, from a political agenda is the net zero targets that were laid out in Glasgow as part of COP26. And I think that is something that we have to be aware of when we are rolling out innovation. And I think 5G has a place for that, because if we can do more in the community, we obviously reduce that net zero and carbon emissions. One picture that I like to use, and I think all speakers, it's always difficult going at the end of a panel of speakers because everybody said everything that you might want to say. But I think just to reinforce all the messages, what the governments are looking for, and again, this is a global perspective, is shifting the balance of care from acute hospitals, where treatment is very clustered, is very expensive, but we really need to move that. And the ambition is to move that much more to the prevention, detection, post-event care and independent living in a community setting. So reducing that hospital environment and reliance, I suppose. And the good thing is, if we can develop innovations for that in the UK, we can export them. So we get a societal benefit, but we also get an economic impact and economic opportunities that come from that. We've seen for many years lots of different innovations, and Scotland's no different. and lots of promises for telehealth, telecare, and there is projects that have been really successful throughout the UK. I think one key area that we've not been great at is actually taking technology out of buildings. So what I mean by that, and a good example of that, is telecare. You know, telecare is very much focused in a home environment, and I think 5G has got the real ability to take that telecare and transform it into what people do on a day-to-day basis. Another key point that I'd like to make, and again, all the panelists have touched on this, is that really communication is all about joining the dots for me. It's all about enhancing the communication and pulling together all the data from all the places that matter and can have an influence in health and social care. We often talk about the social determinants of health, and if you look at that, only 15% of that is data from hospitals. So the rest of it is actually collected in other places, and I think 5G again could collect real-time data or near real-time data to actually make that diagnosis and other aspects of the health and care system a lot more robust. Some of the projects in Scotland, and you would have seen, I think it was Simon or Tony's slides of all the test beds in the UK. We don't have that many, but we do have a UK 5G centre of innovation, and I know that they are promoting many more test beds. But I did a bit of work around feasibility study, and really it was looking at the rural communities of Scotland. And I think, again, just to complement all the other presenters today, a lot of that has been focused around the urban environment, and rural environments bring their own challenges, but they also bring their own opportunities. In Scotland, you could be 3 to 4 hours away from a hospital. So the opportunity for 5G to actually plug some of the gaps and introduce innovation into service is a real opportunity for rural areas. When I was speaking to the health and care practitioners in the rural areas, some opportunities arose. Things like pop-up services. So you see the mammogram van, parking in the supermarket car park. And obviously that screening service, you go in, you get screened, that's great, it's a great service. However, that time delay to actually transfer the images or any queries that people have to an expert consultant, there is a time lag there. So you could imagine a world that 5G might be active in that car park, and the 5G and the images could be transferred maybe in real time eventually in the future. And I think it was Tony that kind of stole some of my thunder about the colon capsule endoscopy. We have ran that in Scotland, and we are scaling it, not using 5G, but we do see real opportunities of that remote diagnostics within the community, and allowing people not just to have to sit in their house with the capsule going through, but being able to go their shopping, etc., while the images are still getting transferred using a potential 5G connection. Another opportunity that was flagged from a rural perspective was post-event trauma care, and Catherine eloquently put her story forward about her father-in-law. And strokes is a real need, because if you have a stroke and you're in a rural community, the need to get to hospital is paramount, and the need to get that expert consultant at the other end of that paramedic or ambulance driver is really key. And sometimes paramedics turn up at homes or in rural areas that really do not have a good signal. So having that 5G reach could be a real opportunity for them to have positive outcomes for health and the person who's at the centre of the care. Roadside accidents was another, because often you do need to deal with the accident at the scene of the road, and it's important that you can bring the right expertise in. Again, connectivity has a real bearing on that. The last is really around next generation telecare and actually taking telecare outside the home. This is actually on the right-hand side a picture of my father. My father had dementia for 5 years and unfortunately passed away this year. However, my dad in the early days of dementia loved to go hill walking, loved to take his dog out. And that was restricted because of telecare in a way. And the problem is he would then go out with the dog early on in his dementia and he would get lost. He would start to wander. And that put enormous stress on the family, but it also put enormous stress on the services like the police force, you know, that were then having to go out and try and find him. Luckily, he always did return home safely. But that's another way that if we did have 5G and we did have really good innovation that could wrap around that care service, we could actually allow the people to go outside their homes and get on with their everyday life. So really just to summarise, I think there's great opportunities. You know, Scotland's not very well coverage wise from a 4G perspective, but I know that's improved over the last couple of years. But I don't think the whole story is about technology. I think, as a number of speakers spoke about, it's about the service. What does the service need? And are the service willing to redesign to enable that technology to be part of that pathway? I believe there is a willingness, and I believe that we could build the evidence for that with the test beds. So thank you very much for listening to me.
Everybody working? Okay, good. So thank you very much. I would like to open it up to the audience for questions. If not, I've got some questions. All right, sir, in the interesting looking. Sorry. Oh, do you have a microphone?
Hi, my name is Harpreet. I'm from the Tata Group. Probably a lot of people know Tata's as Tata Cars and Tata Steel, but they're also in Tata Hospitals. They've got Tata Telecom and 5G network as well. So I'm representing Tata Healthcare here. Firstly, thanks a lot for the presentation. I think it was a very good perspective because you spoke from different angles, both public sector, private sector, as well as health and social care. So thank you for a very joined up presentation. The question I have is, we're speaking about technologies downstairs, a lot of it related to AR, VR, and of course those technologies are great in themselves, but they can't work without tech supporting it at the background, right? Like supporting it. So given that in the recent budget, the Chancellor has announced a lot of money, over 5 billion for health and social care. From your personal experiences, I just wanted to, gauge your thoughts in terms of where you personally feel, most of those funds should be directed, which can give maximum benefit to patients and citizens in general. Thank you.
So can I turn to, I'm going to turn to Peter first, I think.
If this is on. Okay. For me, the really important thing is for those kinds of questions is return on investment. I don't think that we should be looking at this through a lens of what's a whizzy technology right now, how can we go out and get it embedded. We need to be looking this through a lens of what is the use case for this, and therefore what kinds of technologies do we need to put in place in order to meet a clinical or a social care need. Having said that, I also do think that we need to look at the kind of enabling layer as a whole piece. So as I said in my talk, there are sort of groups of business cases that are around getting patients out of hospital. There are groups that are around supporting people with being able to live healthier lives. There are groups of business cases that are around prevention. We do need to look at those in the round, because if you look at them as just individual, a business case for I don't know, putting in a remote monitoring solution, that doesn't give you the kind of level of investment that you need in order to put in a technology like 5G, which will support a whole raft of these mini business cases. So it is a bit of a balancing act, I think.
Is it this one working as well?
Yeah.
Good. Okay. So I'm just going to give you a little bit of government perspective on that, which is to enable all the things Peter talked about there, actually crosses quite a lot of different government departments' briefs. So whether you're talking about the levelling up and cities and local growth department, or business enterprise innovation and skills, or if you're talking about DCMS, which is digital brief, or the Department for Health and Social Care, we need to join up a lot of different pieces to make that business case stick and to create the right circumstances for us to move. And I think we talked about earlier about the realization of those benefits and the conversion from pilot to a nationally rolled out service. So a lot of the money that was allocated in the budget to the NHS was for connectivity, basic connectivity, well, actually gigabit connectivity for NHS buildings. Now that's really, really important. We've seen all the, those sites where it's important for us to have the best possible ability to realize services, to get data in and out of those environments, back to the cloud, or to other institutions where it's going to be used. So whether that's the primary healthcare trust or the doctor's surgery or a clinician in some other setting. But if you don't link that up with the rest of the work that we're doing with Building Digital UK, BDUK, which is a DCMS arm's length body, to connect up the rest of the nation, then we can't do the bit with the capsule endoscopy that then takes those images and connects them back into the NHS building where a surgeon or a consultant is going to look at those images or look at the AI processed images and come up with some conclusions about treatment. So for me, it is hugely about joining things up. And that probably extends to Department of Transport. In other words, how do we get logistics to work well across between those buildings, between those different settings, as efficiently as possible? So this is joining up a lot of government departments, and that's what a lot of Whitehall is focused on today: is how do we make that work together, not just our own parochial kind of interests, but make it all work for everybody. So.
Can I go to Jeanette to answer that question, and then I'll come to Anne afterwards.
Yeah, no, thank you. And thank you for your question. I think from my perspective, it's less about the technology once it's proven. I think it's actually about the service innovation piece and giving the hospitals, the health and care practitioners, the conditions to innovate, to also develop new service models that embed that innovation. There's not that much funding across the world, globally, at government to actually do the service innovation piece, which then, going back to Peter's point, ends up meaning the business case doesn't stack up, because it's got to be a whole system investment and return. So that would be my answer.
Hello, sorry. Having introduced some new technologies, digitalised the domiciliary care services. So everybody who gets a care package in Liverpool now, it's done through digital smartphones, got European money, those were the days. What we found was that was a huge piece of change management And I think that's one of the biggest things that often is missed in all of this, is actually the time and effort of staff to actually get a new way of working. And that's basically what we're asking for. We're asking to start using new technologies. So as well as the whiz-bang things that we're wanting to introduce, and the connectivity, which I feel is crucial, we also need to invest in the staff so they understand what the changes are, how it works, what the improvements are. Just a very quick example, when we were introducing the digital domiciliary care services, we had a series of training sessions on and nobody was turning up. And then we changed our language and said, we're going to show you how the app works on your new smartphone, full room. So it's about working with people to get them to come along with you, because if you don't bring people along with you, you're just going to have lots of fancy equipment just sitting around.
Yeah, I think I would just back up the last two. I was going to say platforms, service platforms, and skills would be my two focus areas. I think, and they were both reinforced by the two previous ones. I think that the issue in particular around platforms is, I mean, connectivity is important. Getting the pipes and poles in the right places, but then there's a data layer, a business operations layer, so to speak, that needs to be coherent across not just indoor but outdoor. So you have to think a little bit like a mobile operator and try and go for a universal coverage view of the world. But as I said, those mobile operator networks at some point will fall down because their business case is focused on consumers and smartphones. And there are some interesting use cases in the health sector where the operators are going to struggle with their existing infrastructure and their existing supply. So, and that's where there needs to be skills on the health sector side that can draw in either from the private networking side or from the public networking side a solution.
Joanne, do you have anything to add? Joanne, you're on mute. The on mute.
Sorry. No, I fully agree. The important thing is how to make the change in the way we deliver services. And that means to know exactly what we want to achieve. And once we know what we want to achieve in our clinical side, our clinical practice, in the patient safety and companies, when technology plays a big game here. But sometimes it's the contrary. We put technology before the clinical and it's not working. I agree with you. And it's a big job because the problem we have, and finishing here, is the narrative, how we explain that to the people deciding. No, it's difficult to understand the change, and that is still lacks a narrative explaining exactly what is happening and how it can be improved, how we can be better.
Thanks.
Thank you.
And any other questions? Bob?
So, hello. I was struck by two things in the presentations, well, many things, but in the presentations that I've listened to. The first was, Simon, you talked about 2 to 3 years, maybe 4 years in the way that some of these technologies might be rolled out. And Jeanette talked about the very real crisis or difficulties that the health systems are in at the moment because of COVID, etc. So what is the one thing that the panel thinks can pick up the pace so that these solutions can be actually affected and really begin to deliver patient care? What is the thing that will pick up the pace?
So if I can just call on Joanne and we'll go back to front. What's the one thing that's going to pick up the pace, kind of drive uptake, or whether it's a technology uptake or a person uptake? So Joanne, over to you.
Oh, thank you. Well, one thing, I think the example we have now is the imaging, medical imaging. We, in a few years, have been changing a lot, no? And the thing is, the problem we have is the silos in healthcare, silos. And these silos are not connected. And sometimes it's difficult to get things like new technology or new transformation, which is more transversal. And for me, the thing my answer is how we have a clear picture what we want to achieve If not, it's difficult to make anything change.
Jeanette.
Thank you.
So a clear picture, that's number one. Number two, Jeanette.
Yeah, I mean, I think for me it's collaboration. If you look at COVID and the crisis, we were actually involved in an application that went national and it was delivered in 52 days. And the reason it was delivered in that time is because there was a political mandate. There was people working across the system to get rid of barriers within days, which would usually take years. So I think it's that collaborative working and acceleration of innovation. And I think that has got to come from a political perspective as a mandate.
Okay, thanks. Tony.
I'm going to pick culture because I don't think there's any of this really changes until people think differently about how to solve problems together. Good example, actually, going back to Jeanette's point earlier, was the capsule endoscopy thing. In Scotland, you're quite right, went for it, decided it was ready to roll out, and have been rolling it out successfully. NHS England decided they needed to do another trial. I don't really think there's a big difference, apart from perhaps consumption of whiskey, maybe eating haggis. That's the big difference between Scotland and England. But there's actually zero difference in the clinical situation there. So why do we need another trial? So I think that culture that we need to, we're different, we're special, we need to do things differently because we're in a particular hospital, a particular trust, or a particular geography, that we need to do things our way. I think if we get over ourselves a bit, and that goes for government too, and work together towards common solutions, common causes, and get up and cure the ultimate disease, which is pilotitis, then I think we can get a long way.
Simon.
You just stole my thunder with the last one, the pilotitis. But I think pilots are very important, and certainly a lot of my past history working in the mobile operator sector, and you do proof of concept. You prove out things, but then generally there's a degree of collaboration, coordination. There are some big vendors who will knowledge transfer amongst the community, and things roll out quickly. And that somehow we need to recreate that, and that's exactly what the point that I think is important here with these sort of technologies. Once you prove the concept, that it needs to be trusted by others, that there's been enough of a proof point, and start accelerating the investment and other people using those approaches. I think Liverpool's a fantastic example, actually, of things where you can see people using it and learning, and then there's a lot of effort to evangelize those use cases, not just the technology. The technology is the technology. It's the benefits of the people using it, and that's an essential part of what needs to happen to accelerate.
I'm seen as a Cinderella because I'm from social services, so we get next to nothing. So it's really, really difficult at the moment. And I think the pandemic and the crisis that we're facing in social services is almost bringing down the NHS, because there's nowhere from the hospital to discharge people. So I get every day, and I did look before, so there's 134 people in Liverpool waiting for care packages. So that's 134 people. Some are already in the community, but we've got to try and find someone to care for them. And I think there is some technology that can help with some of that. But we've got to make sure, and it comes back to this change management of a different way of working. And I really hope that all the money that the Treasury are giving to the NHS is just not going to be thrown in the same way, because that's not working. So I don't think there's a quick fix. I think it's going to take time. I think there's a very unpalatable for Treasury. Why are we still paying our care workers the minimum wage? I was speaking to a care company earlier in the week, and they were saying that Lidl are now paying £10.50 an hour. So if you can work you know where your hours are, you're not going through the awful weather, knocking on people's doors, etc., etc. we can't pay £10.50 an hour. We just don't have that funding. So I do think there is some, still quite a lot of fundamentals we've got to get right, but it is a big piece of change management. And we've also got to improve, I think, the piece that was made about skills. It is a skills thing as well, that people are frightened of some technology. And you'd be surprised, actually, it can go from the consultant right the way through to the student nurses. It's not an age or a gender or a generational thing. There is a real, there are some people who really struggle with technology, and I think we've got to bring them along as well.
So I think it's really straightforward, actually, and I think Anne and some of us have brought it out. If you want change to happen, you have to invest in it. So, hands up, all the people in the room who've run projects where you've put in technology and invested nothing in skills and change management. We should be completely rejecting, project proposals where we don't do that. We need to invest in co-designing with the staff and the patients. We need to invest in them engaging through the development process of whatever it is we're doing, and we need to invest much more heavily in that kind of last step, completer, finisher, embedding whatever the service change into the way that we work, and that's the way that we'll be successful.
I agree. So I'm going to recap. So have a clear picture, be collaborative, and politics or the government needs to be involved. It's a bit of a culture change. You need to do do your pilots and get on with it, and do your pilots and get on with it. We need a different way of working. We need to look at things differently. We need to value things differently. That's what I got from what Anne said. And we need to invest. So I'm going to give an example, Tony. You've heard this already. So a friend of mine his mother decided she wanted to stay in the house, 95, 94, something like that, but she kept falling over. So they got her a necklace with a button, and she pressed the button, and actually a service comes immediately that's fairly close to the house and helps her get up. It's quite costly. He comes over, she's on the floor. Mom, why didn't you press the button? I didn't want to bother them. It's a different change of mind. Whereas if you had said, okay, Mom, this is what we're going to do. I'm here. You're going to fall over. We're going to press the button and see what's happening. How do you drive that change? I think that's the thing that if I wrote a dozen questions after listening to this, and it's all, how do you drive the uptake? How do you drive the change? And, it is a bit of how do you get government to pay for that? But how do you get the 94-year-old in the community to look at a smartphone and check her blood pressure every day? And then how do you get a doctor to use a different way of doing things? Or somebody gave me an example the other day that they did a trial where they put all of the beds on an IoT. They essentially were tracking all of the beds on a floor of the hospital. And all a nurse had to do was look at a tablet and say, oh, there's a stray bed over here. Nobody went to the tablet. They all went looking. How do you do that? How do you drive that change? And that's the question for the room. That's the question for all these panelists.
Can I jump in one more? So Treasury will open its purse if it sees a strong business case being made. Each one of these interventions on their own don't make a business case. So that's where we have to collaborate across all of these settings to create a substantial business case that makes sense. Then we've got to drive the change that goes with it. But if the evidence is there, and I think that's my call to all of our trialists, whether they're in our program or outside it, is bring the evidence, collaborate and collate that evidence, and we will have enough momentum to make the change and make the investment.
Yes, I think that's a really good point. The other thing that I always come back to when we have a CIO who locally who lives by this maxim, and I think he's absolutely right, which is don't try and get people to do the right thing. Make the right thing the easy thing, which is one of the reasons why I started out with let's get co-designing with our service users, patients, and our staff, so that the systems that we put in place really work for them, and then you don't have this business of, oh, it's on an iPad, but we didn't go and check, because those people are then bought into, and the services that we've developed support them in the way that they want to work.
Joanne?
Yes, very quickly, I agree with you. Some years ago, The Economist said an article saying why in Western world there are no changes in healthcare, and the analysis was in politics healthcare has no weight because it's a commodity. People, doesn't matter who's in government, we have the services. No, that means in the government that to decide to invest money is impassive to avoid problems, no? People getting angry. And the question is how governments take care in a way is good for them. But the elections in the polls, the healthcare is not having weight, unless it's doing something wrong, unless it's a tragedy. And that is the chance, not only in UK, in Spain, in France, in Germany, every country the same problem. You are Minister of Health and your President or Prime Minister says, go ahead, don't make mistakes, don't touch anything, it's not broken, don't fix it, no? And that is a passive way, it's not because it's true. Whatever the Minister of Health does is not being sure you can be re-elected. Depends on the factors, not only the healthcare, it's other factors more complex. That's my vision from The Economist.
Thanks, Joanne. Anyone else? Any other questions in the room?
I'm just going to put on my UK 5G international hat and also my Real Wireless CTO hat to point out that, I mean, we had Netherlands speaking earlier. We've got Spain here. We have a strategic partnership with a company like Real Wireless in Norway in the health sector. You know, there are several countries over Europe who are grappling with these problems at the same time. You know, a lot of these, most of Europe, you know, the public sector is putting a huge amount of money into the health services. As I said, the European Commission study we did, I mean, that was one of the top level investment priorities for 5G. You know, big GDP benefits, cost savings, productivity, efficiencies, the health of the nation is important, etc. So I think that outreach to other countries to work out what is and isn't working is also very important here.
Question? Okay. Thanks, Tony.
Hi, I work for a company called Metrocell, and we do a lot of test and measurement of mobile networks, so for operators, but also the emergency services network, for example. Testing that measurements are fit for purpose will become a lot more important when we're using 5G for these sort of life or death scenarios. Is that something that was covered at all in any of the projects that you've discussed today?
Yeah, obviously that's something we're looking at very closely. And one of the things about having a private network to deliver these services is a better service level agreement. So we're building into our network service level agreements, which I know the big guys can provide, but at a cost. So we're keeping it very local to the to Liverpool city region area. So we've got people who can come, and we're working towards, if a device fails, then the person who's referred them into that service will hear within 15 minutes. And then we can take it from there in terms of, we're saying a maximum of 4 hours to get the service back up and running. Obviously, there's going to be problems with power lines and things like that. That's not going to be completely for all of them, just based on what's happened in the storms. You have to see what's happened in the northeast. So there are going to be some issues, but yeah, we can offer better service level agreements.
Can I point out there's a small elephant in the room, which is called non-standalone. So in the public networks today, all of the 5G that you see today is built on top of 4G. So you might have a really good 5G strong signal on your phone. I just did a ping over there on my Vodafone network showing me 200 meg download, 70 meg upload. Sounds fantastic. The problem is that's not end to end because it's built on top of the existing 4G infrastructure. So the end to end experience might be even slightly worse than a 4G today. All of that's going to change, and Vodafone are going to make this all right because they're going to flip out their non-standalone networks and they're going to replace them with standalone. And at that point, you will get the full end-to-end promise of 5G. Anne's in a slightly different position because the networks that she's deployed today are private networks, so they are standalone. So it's all 5G end-to-end. So you are seeing the full experience of that. But that's going to take a little while to shake up and get through. But measurement of that, again, make sure you're measuring end-to-end, not just radio, not just the air interface.
And I was just going to comment on that as well. It's 5G network. It's a different game. As Anne said, it's different costs for different levels of service. But if you are driving 5G into an operating theater and you need a certain level of throughput, you need a certain latency, you build it for that. And you build the failover because you can't afford to fail. So it really depends on what you're requiring, where you're requiring it. And if you're looking at a hospital situation, you may have super failover in one area of the hospital and not as much failover for your private 5G network in other areas of the hospital, depending on what it's looking at and what it's enabling. And it's really a fit for purpose. And I think that's where private 5G, standalone 5G, and private networks are very different. They're really built to fit the purpose, and they're built for things that are moving around. Any other questions or any more comments from the? On that note, I'm going to take my other 30 questions and hope my colleagues will have some lunch with me. And I want to thank everyone for listening, and I want to please join me in thanking all the panelists. I think they were brilliant. Thank you. Thank you, Joanne. Thank you, Jeanette. Thanks for joining us.